Thank you, Dr. Temte. Many of you should be familiar with the General Recs process and procedure by now. We've been through a number of these today. Andrew Kroger will be updating us on the general recommendations work group deliberations around altered immunocompetence. And just by way of background, the general recommendations work group publishes every 3 to 5 years updated guidance that addresses a variety of immunization issues relevant to all vaccines and topics that cannot be attributed to a single vaccine. This is the lovely cover of the current edition. So we've been through a number of topics with your assistance. The topic for today is altered immunocompetence and vaccination programs. And Andrew has done an outstanding job with these. We're basically through the updating process. A very small bit of information needs to be revised, and then the updated recommendations can be published. I want to particularly thank Dr. Lori Rubin and colleagues at the Infectious Disease Society of America, because much of what we've done today, and you'll hear from Andrew, has been to integrate their new guidelines for vaccination in persons with altered immunocompetence with the existing ACIP guidance on vaccination of persons with altered immunocompetence. And this is an increasingly complex area. We very much appreciate the collaboration with the Infectious Disease Society. So I want to also thank Andrew again for his leadership and also thank my colleagues for their tremendous contributions on the working group.
Thank you very much, Dr. Duchin. As Jeff mentioned, there are basically 2 sections left. I'll be discussing them both today. I'll start with altered immunocompetence, and then I have a few slides on vaccination programs. The majority of the discussion today will be focused on the altered immunocompetence section. A lot of the vaccination programs section is programmatic, and there just is not that much that's changing from the 2011 document. I'll go over both of these sections today, and then we'll move on to the discussion period for both. ACIP members should have really 4 documents, one for each section, both a clean copy and a track changes copy. As I go through the slide set today, I'll be referring to page numbers and line numbers that should match to your track changes or dirty copy that you have in front of you. Sometimes there's a little bit of variation depending on your printer. It might not line up exactly, but I'll try to kind of work you to the right section of the document when we get to it. So I think it's important to start with a bit of background as to what's already in the 2011 general recommendations. And so here is a slide that shows you the different really parts of this section. There is a discussion of general principles, which basically defines what altered immunocompetence is. We're talking about immunosuppression or immunodeficiency. They're really all synonymous. It does refer to a table that describes broad categories of what altered immunocompetence is. More importantly, in this first part, there is a statement, which we don't anticipate changing at all, that says that when there is deliberation to occur, providers are always welcome and encouraged to refer to another treating provider, someone that may be an expert in infectious disease or immunology. So that is always going to be an important part of the process for providers. There's a section, altered immunocompetence as an indication to receive a vaccine. This describes those situations where we actually may recommend a vaccine outside of a routine age group because altered immunocompetence is part of the patient's profile. There is then a section on vaccination of contacts of persons with altered immunocompetence, emphasizing the need to provide that community immunity. Then there are two sections, vaccination with inactivated vaccines and vaccination with live attenuated viral and bacterial vaccines, that basically highlights, first by way of general principles, the fact that we are concerned primarily with efficacy issues with inactivated vaccines and both efficacy issues and safety issues with our live viral and bacterial vaccines. There is a section on hematopoietic cell transplants. And lastly, there is a section on conditions or drugs that might cause immunodeficiencies. This is kind of a section that highlights those topics for which it's difficult to apply general principles, difficult to say in all cases you would withhold all live vaccines, for instance. We're talking about certain conditions like asplenia, and then another complicating issue, which has really been topical recently, are the new drugs that cause variable levels of immunodeficiency. So that's what that last section was all about. So this is what's in the document already. And so this was the challenge, is to revise this document revise this section for General Rec's Workgroup. And I want to point out, as Dr. Duchin mentioned, both just today and also at the previous ACIP meeting, guidelines from the Infectious Diseases Society of America were published in 2013. Clinical practice guideline for vaccination of the immunocompromised host. As far back as November of 2011, CDC was involved with crosswalking topics in this draft for this document, to crosswalk it with existing ACIP guidance, both vaccine-specific ACIP guidance as well as ACIP general recommendations guidance. The document is now published. As you can see, Advanced Access was published December 4th, 2013. And so, and the document has as authors, first of all, its first author, Lori Rubin, who's a former member of the General Recommendations Workgroup and current ACIP member, as well as Harry Kaiserling, who is also a former member of the General Recommendations Workgroup and also was a current member. Dr. Kaiserling was a current member of the workgroup while these deliberations were ongoing. And so this is a very important source document for changes to the general recommendations. And it means we have to this is more background information that we have to get out, that there will be some differences always between two groups. And so I just want to make the point with this slide that the primary differences that may exist between IDSA and ACIP really occur at the level of vaccine-specific recommendations, and so are not a part of General Recommendations Workgroup process. There are some specific recommendations for use of particular brands of HPV for immunocompromised patients. Gardasil, for instance, we don't state such a preference in ACIP documents currently. The other kind of identified difference is a recommendation for varicella vaccine for immunocompromised persons within certain parameters, right? Certain T lymphocyte levels. You have to achieve an immunocompetent level before you would recommend varicella vaccine. But after that, the IDSA document would recommend its use. ACIP maintains a weaker strength of a recommendation, even in that circumstance, and they use the term consideration. So this slide just shows you that there are going to always be some differences. Work is ongoing to clarify these differences. Discussions are occurring with vaccine-specific subject matter experts to try to make sure that whatever comes out in the ACIP General Recs doesn't conflict with a vaccine-specific statement. Nothing in the current draft that you have in front of you should violate an ACIP vaccine-specific document. And again, we'll have to address this in the future if it does. That really is the purview of the vaccine-specific ACIP workgroup, not the General Recs workgroup. So I'm just going to kind of go through what is changed in the general recommendations document, because as I mentioned, there was a lot in the 2011 version, and it really does need to be updated, and there is a lot of important information in the IDSA document. as well as other source materials. And actually, here's an example, altered immunocompetence as an indication to receive a vaccine. Most of the primary source material for these changes do not come from IDSA. They come from the vaccine-specific ACIP statements. And what we're talking about are recommendations for the use of pneumococcal vaccines, meningococcal vaccines, Hib vaccines in patients that have conditions such as asplenia, anatomic barrier defects, CSF leaks, and cochlear implants. So we have tried to harmonize the language in the general recommendations document with the new information in the vaccine-specific documents for these vaccines. Really, where we bring in IDSA information is the sections on vaccination with inactivated vaccines and vaccination with live attenuated viral and bacterial vaccines. So I'm going to focus on these two and start with inactivated vaccines. Just again, by way of the background principles, when we're talking generally, we generally make the statement that inactivated vaccines are safe in patients with altered immunocompetence, but that there are, of course, efficacy issues with both live and inactivated vaccines with certain diseases. And there are some specific diseases listed in the IDSA document that we would like to incorporate into the general recs. So this is in the section where we discuss inactivated vaccines efficacy issues, which is around page 4, line 26. We include from the IDSA document information about B-cell deficiency and receipt of immunoglobulin therapy, a recommendation to withhold both inactivated vaccines and by extension live vaccines. But again, this is an efficacy issue. Patients on immunoglobulin therapy are thought perhaps to have reduced response to even inactivated vaccines. And this is kind of something that's new to the general recs. Likewise, cancer therapy and receipt of anti-B cell therapy, and the candidate drug is rituximab. We do have now, or we hope to incorporate from the IDSA, a recommendation to delay inactivated vaccines 6 months, and again, this would be an efficacy issue. As far as the section on live attenuated viral and bacterial vaccines, we're talking safety and efficacy. And we include some information about specific diseases on page 5, line 4. We provide some clarification, and this will have relevance to the categories that we split out in our table as well. For instance, we describe chronic granulomatous disease and that condition as a reason to withhold live bacterial vaccines. However, with other phagocyte deficiency diseases such as leukocyte adhesion deficiency, Chiari-Higashi syndrome, this is a recommendation to withhold both live bacterial and live viral vaccines. 2011 General Recs is simplified in that it only recommends live bacterial vaccines, so this is new information from IDSA. We really don't want to get into these specifics in the print of the General Recs document, but this has to do with the risk of these particular types of infections with chronic granulomatous disease, deficiencies in the oxidative burst associated with intracellular killing. Patients have increased risk of bacterial infections. However, with these other conditions listed here in the first two bullets, LAD and Chiari-Higashi, there are issues with adherence, issues with defects in natural killer cells, CD8 T cells, that generate a risk for viruses and bacteria. So we needed to fix this. There also is some information on conditions such as interferon gamma, interleukin-12 axis deficiencies to withhold live bacterial vaccines, as well as defects of interferon alpha or interferon gamma to withhold live bacterial and live viral vaccines. And again, that is a risk issue for those two conditions. And as mentioned, and I'll show you this is kind of a quick shot of the table. Here's a blow up of what that table looks like currently in this section. So you can see there's 5 columns. The actual category of risk is listed in the left-hand column. Specific examples of immunodeficiencies in the next column. The specific vaccines that are contraindicated. The fourth column would indicate whether there's a risk-specific recommendation to use a vaccine. And then lastly, additional effectiveness and comments. So this will be updated as well to incorporate the information I just shared with you on the previous slides. Hematopoietic cell transplant patients. So the 2011 General Recommendations document refers to the source, Tomlin, Chiller, ICIL, Biology of Blood and Marrow Transplantation from 2009. When this was discussed in February of 2009 for the last iteration of the General Recs, there was a recommendation to specifically reference this document by ACIP, and we followed that recommendation. We had the document readily available for those using CDC's website, and we tried to incorporate as much, you can't put everything in, but as much as we could into the document. Now the IDSA has a document as well that addresses hematopoietic cell transplant patients. By way of background, this is a special category of altered immunocompetence because the patient is not only immunodeficient as a result of either underlying disease or treatment, but also is considered to be immunoablated. And what that means is basically their entire immune history is completely removed. So we're not only talking about concerns about which vaccines to give, are there contraindications, are there precautions, but we're also concerned about revaccinating patients that have had HCT. And so the IDSA document really is remarkably similar to the blood marrow transplant document from 2009. They're basically identical for the pneumo vaccines, in which we have a specific series recommended post HCT. Zoster vaccine, rotavirus vaccine, not recommended after HCT, so that remains the same. And the IDSA document is remarkably flexible with respect to different strategies for these patients. Often there are multiple options presented, specifically with the use of pertussis-containing vaccines. That's a kind of, I think it's a unique issue with respect to HCT because in this circumstance, while patients that receive HCT are immunoablated. There is the issue of what the routine recommendation is for the use of pertussis containing vaccines in patients that have received HCT or not. There's almost a natural, I won't say it's natural ablation, but there's a natural waning of immunity anyway. So we have to reconcile these two issues. And I think the IDSA document does a good job of providing some multiple options for patients with respect to use of pertussis-containing vaccines post-HCT. There are some changes, however, from the 2009 document. HPV vaccine is recommended post-HCT in the IDSA document. Varicella vaccine is recommended in the IDSA document. Of course, as long as the patient is immunocompetent, does not have graft versus host disease, and is 24 months post hematopoietic cell transplant. So that would be a new addition to general recommendations. Lastly, the issue of conditions or drugs that might cause immunodeficiencies. IDSA's document kind of cuts its categories a little bit differently than ACIP traditionally has done. It does define different levels of immunosuppression as kind of high or mid-level immunosuppression. In IDSA's document, high level would include cancer chemotherapy. It would include solid organ transplant rejection therapy. Whereas cancer chemotherapy, the recommendation would be a 3-month withholding of live vaccines following therapy. It's 2 months for solid organ transplant rejection therapy. They also define high level as daily corticosteroid therapy with a dose 20 milligrams or higher prednisone equivalent. The previous general recommendations document relegated that usage to a lower tier, but that is considered high level in the IDSA document, as well as receiving immune modulators such as tumor necrosis factor alpha inhibitors or anti-B cell agents. So those are a small change there. The low-level immunosuppression includes what ACIP previously considered not immunosuppressed at all for the purposes of some drugs, including alternate dose corticosteroid therapy, as well as the vaccine-specific recommendation that for patients on specific doses of methotrexate, azathioprine, or 6-mercaptopurine in doses specified in the zoster vaccine-specific statement, the withhold recommendation is 1 month for live vaccines instead of 3 months. And so basically, IDSA defines an interval following the use of a medication, such as tumor necrosis factor alpha inhibitors or corticosteroids. And low dose would be a 1 month interval. High dose would be 3 months, unless otherwise stated. I've mentioned solid organ transplant. Anti-rejection is 2 months, and anti-B cell therapy has a 6 month interval following administration of both live and inactivated vaccines. And there's a bidirectional nature to this recommendation, right? What do you do if the vaccine is given first? And IDSA has made some changes here as well. For live vaccines, they recommend withholding the live vaccine unless you're 4 weeks before beginning of therapy, and a full recommendation to withhold 2 weeks before beginning of therapy. So the provider would use this information as if the vaccine is given first, what is the threshold by which you would need to wait until you start your therapy? And for inactivated vaccines, and this is new, a recommended 2-week interval from the inactivated vaccine before beginning the therapy. So that in a nutshell is the changes to the altered immunocompetence section of the general recommendations that the workgroup has been discussing. I'll move quickly on to vaccination programs, and this is a shorter discussion. And so you should have a track changes document as well on vaccination programs. The 2011 General Recs divides up discussion into vaccination of children and adolescents, adult vaccination, evidence-based interventions to increase vaccination coverage, and other general programmatic issues. What have we done in the work group? We have included the adult vaccination standards. We actually discussed them in the introduction to the entire vaccination programs section. We have cleared language to discuss the Affordable Care Act, inserted into the document, effective for all health plans, drafted or updated after September 2010. The ACA requires plans to cover ACIP recommended vaccines without deductibles or co-payments when delivered by an in-network provider. We put that content in the section while, of course, applicable to both adult and childhood vaccination. There is a discussion of barriers to vaccination in the General Recs adult component of this section. And so that's where we did insert this language. But of course, ACA does apply to both childhood and adult vaccination, although I think it can be argued that the impact might be a little bit larger with adult vaccination compared to child vaccination. That's where it is. We removed, the 2011 General Recs had a lot of information on cost effectiveness, and we decided to take that out. For one reason was it caused an imbalance in the document. We had a lot of cost effectiveness information in the adult section, but we had really no cost effectiveness or cost saving data described in the child section of this document. And so that's kind of the reason for that had to do with the fact that when we first built this section in the General Recs, we were incorporating ACIP-specific documents about adult immunization, about the AFIX program about VFC. So it's kind of just a function of how we put the thing together. So to balance it, we took cost effectiveness discussion out, and really that's best discussed in vaccine-specific recommendations anyway. The last change to this is our strategies table. We updated this. The source material is the Task Force for Community Preventive Services, and there are current updates to this now in the draft from the website listed here. Task Force has removed the word strongly. Now it states recommended, so they've kind of changed the way they describe recommendations. They've made a change to certain recommendations as well. For instance, they had patient or family incentives or sanctions that was previously listed as insufficient evidence. So in the meantime, or in the interim, task force has kind of divided that term out into patient or family incentives. That is now recommended, and sanctions are not recommended. So the table has been, and this is kind of a screenshot. Here's a better picture of how it looks. You can see they use terms recommended, not recommended, and insufficient evidence. So the next steps, is some discussion today on these two sections, with some anticipation that we're no vote today, of course, but we will have a vote hopefully in October 2014 with really the remainder of the entire general recommendations document. All the important sections have been discussed by ACIP, with the exception of the introductory paragraph as well as the vaccine information sources, and I will update those two sections and have the entire document, one clean, one with track changes, for a vote in October 2014. And just by way of a preview, some areas that need some tying up, you might say, just to jog your memory. We made some significant changes with respect to vaccination of the hospitalized patient and all the attendant interventions such as anesthesia, surgery that may occur in hospitalized patients. We discussed alternate routes and whether you count doses given at alternate routes. That needs to be tied up. And of course, febrile seizures as well. There will always be continuing discussion on that issue with respect to simultaneous vaccination. So with that, I'd like to also thank the members of the General Recommendations Workgroup, with special thanks to Dr. Jeff Duchin, outgoing chair. It has been a pleasure these last 4 years working on the document. A lot of very complicated subject material that I just mentioned we went through, and I think your meticulous but easygoing style has made it very, very pleasurable to go through these complicated topics. So thank you very much, and I'd like to open it up for discussion.
Thank you, Dr. Kroger, for a very thorough and succinct report. Questions or comments here from ACIP? Or from Dr. Riley.
I just have a quick question for you, and it may be because I missed it. So I obviously do high-risk obstetrics, and we are not uncommonly asked about women who are on rituximab, say, for their Crohn's disease or whatever. So is the recommendation, we have not been delaying their vaccination because of we may only have 6 months of pregnancy. So what is the suggestion? And if there is a suggestion, I think it should be incorporated somewhere, because the natural reflex is going to be not to give it.
This is something that is being newly discussed by CDC, and less so the issue of vaccination of the pregnant woman herself, although that's an important topic, but we're also discussing the issue of whether immunodeficiency can be transferred to the infant. That is being discussed. That has relevance with rotavirus vaccine, which is given in early infancy. So but I don't know how much movement we'll have on those recommendations. It might be in the rotavirus vaccine specific statement, that issue. as opposed to the general recs. Maybe we can get it in the general recs as well somewhere. The issue of vaccinating the pregnant woman herself, I mean, there's a general recommendation that, and it's not in the altered immunocompetence section of this document, it's in the pregnancy, that live vaccines generally are contraindicated in pregnancy. So it's the pregnancy itself might contraindicate the use of these medications as well if we define them as immunosuppressive. So it is something that I guess might need to be discussed further as we go back over the special situations section of the general rec, which includes a discussion of pregnancy.
So my point is, just to clarify, only for those vaccines that are recommended in pregnancy, so the inactivated flu vaccine, the Tdap that we should be giving, you'd hate to see people delaying that because of this 6-month concern, because we'll miss the ability to protect the infant. So it's just something to consider.
Okay, thank you.
Yes, Dr. Rubin.
Yes, although I would say in the case of rituximab in particular, where studies have been done vaccinating people that have received rituximab, since it's essentially a B-cell poison, they just don't make antibody. So if we're relying on humoral immunity, there's quote-unquote no point. The likelihood of significant effectiveness is extremely low.
So would your suggestion be don't bother in those patients because it's not
That's
going to help?
my personal suggestion is that there's there's very little risk, but the likelihood of a positive effect is virtually zero, so I wouldn't give it.
Yes, Dr. Harrison.
So I may have missed this, but are we going to attempt to harmonize with IDSA, or are we going to remain divergent?
The general recommendations is going to be harmonized, I hope, with IDSA. That was the goal, to harmonize. It does involve a degree of cherry-picking recommendations from the IDSA document, and so that is what we've attempted to do in this draft, as opposed to not putting content into the draft and just putting a citation. And there will be ongoing attempts, of course, there is discussion with vaccine subject matter experts on specific issues that may appear in vaccine-specific statements that may not, harmonize precisely with what's in IDSA. But that's really outside the purview of the general recommendations workgroup if it's something that's specific to one of the vaccines. That work is ongoing. I mean, there's recommendations for use of zoster vaccine that's not harmonized with ACIP specific but the vaccine subject matter experts are aware.
Any other question or comment? Seeing none, I will invite Dr. Jenkins to come up and introduce the section on the Child and Adolescent Immunization Schedule.
Good morning. I am pleased to introduce the report of the Child and Adolescent Workgroup. We're going to first just thank the workgroup members for their input into this project, which is basically introducing the job aids that go with the catch-up schedule. And the workgroup members are listed on this slide, and our CDC lead was initially Yabo Baisalo, who some of you know is no longer with our work group. And Ray Strikis is actually the CDC lead. Ray had a conflict today, and so Andrew Kroger is going to present the report. Basically, we're going to review the status of the childhood immunization schedule, review the the accessibility of the catch-up schedule, and then look at the initial work that's being done on job aids. I think the goal of the work group is basically to provide tools to providers to be sure that providers can give the closest to recommended schedules, and when the schedules are not kept, to know how to proceed effectively. And so Andrew will present.
Thank you, Dr. Jenkins. So CDC has two childhood immunization schedules in use. The first one is the recommended immunization schedule, and the second one is the catch-up schedule for kids that have either missed vaccines or are behind in this schedule. And I guess the recent efforts of the schedule work group have been an ongoing effort, I guess, that's been going on since 1964, as mentioned at the beginning of the meeting, to clarify the schedule as it has become increasingly complicated, and even more so recently. Here is an image, figure 2 of the childhood adolescent immunization catch-up schedule. There is very dense text in some of the cells, particularly for Hib vaccine, pneumococcal conjugate vaccine, to a lesser extent, DTaP vaccine and Tdap vaccine. So just to really help providers be able to read the small font that is in the schedule, the work group has attempted to create tools to help providers with this catch-up schedule. CDC and partner organizations have developed job aids, or we're in the process of developing job aids to be used with the current catch-up schedule. ACIP members have one, an example of one in front of them right now for tetanus toxoid containing vaccines, DTaP, DT, Tdap. But for this presentation today, I'm going to be presenting the efforts of the work group. Basically, what we did is we wanted to test the job aids. We wanted to learn from practicing providers their current usage of the catch-up schedule and how it could be improved so that a catch-up schedule can be made more user-friendly. So CDC created originally job aids for 2 vaccines, Haemophilus influenza type B Hib and the tetanus toxoid containing vaccine job aids, the example of which you have in front of you. We also borrowed 2 job aids from the Immunization Action Coalition, the pneumococcal conjugate job aid located at the website you see here, and the meningococcal conjugate job aid. And what we did was we tested these job aids in variable formats, actually, with healthcare providers. We kind of sometimes we showed formats in algorithm form as opposed to table form, and we broke the table up in different ways as well, and shared shared these job aids with the providers. So I'd like to kind of discuss the nature of this field test. These were our target audiences for our field test interviews. They included family practitioners, pediatricians, public health nurses, nurse practitioners, nurses in private settings, physician assistants, medical assistants, and immunization information system or registry staff. We chose these groups because of their role in vaccinating children. We identified for physicians, we identified those that were board certified in pediatrics or family practice. We wanted to make sure that the participants that we interviewed reported spending 50% of their time in direct patient contact. And that involved them reporting that they recommend immunizations for at least 5 patients per week. And they had to report that they worked primarily in a private practice or public health clinic that provides immunizations to children. The qualifications did not apply to participants who worked at the state registries. So in order to find these providers, we used these professional organizations in mid-February to recruit participants, and they're listed here: the American Academy of Pediatrics, the American Association of Family Practitioners, the American Nurses Association, the American Association of Physician Assistants, and the National Association of Pediatric Nurse Practitioners. We also contacted state health departments and state immunization registries. Our original goal was to contact about 10 to 15 people from those 8 provider groups, hopefully to give us a little under 50, taking into account the response rate that we would have. We'd like to have a little bit, about 50 responses. We ended up receiving contact information for 55 individuals and contacted them. We used the SurveyMonkey internet-based survey to collect our data, to collect the demographic information, and we used it to create a questionnaire for the project. Basically, as part of the phone interview that we conducted, we reviewed the answers that they gave to the SurveyMonkey questionnaire, and then we showed them, they had the job aids already, we gave them these case scenarios for which they could use both the current published CDC harmonized schedule as well as the job aids, and collected information from them about that. Here are the participants that were included, a breakdown by provider type. We started the interviews on March 20th and finished on May 1st. We reached over 50% of the target number for 6 of the 8 groups. We interviewed 30 people total, and by that point, we kind of had enough similarity of responses that we felt it was important to analyze the results that we had. Here, I wanted to show you an example of some of the products that we gave them. So here is an example of the DTAP job aid. I say DTAP, but it includes usage not only of DTAP, but DT and Tdap as well. This is not the entire table. This is basically one of the 4 pages of the table, which is intended for instantaneous use. It's for a provider to, when they see a patient, see what their current age is, how many doses they've had previously, and make a decision about what they need to do today. The last column does have some information about when the next dose is due, but really that content is important for discussions with the patient. It's important to realize that when the patient comes back, they might be of a different age if they lapse, which we hope doesn't happen. They might fall into a different row, but we wanted to put a column that looked prospectively as well. And this is a prospective tool. This is not to be used to validate doses that have already been given. This is something to support use of the childhood schedule moving forward. It's just an easier way to kind of see the information. And I've mentioned Immunization Action Coalition. They have a document for pneumococcal and meninge, which is similar. It looks at the child's age now and discusses vaccination, past history of vaccine, and what the recommendation is ongoing. And so we did include this in our interview in our focus group. You don't have a copy of this in front of you. Where IAC varies a little bit from what we're trying to do is they combine healthy and high risk in one table, which is very, very challenging. It's quite an effort and quite an accomplishment to do that. That is not really our work group's goal. We're kind of going to focus on the healthy child for our tools. So here are some of the results of our survey. Participants felt that the current published catch-up schedule has useful information, but it's difficult to read or understand. The footnotes were brought up often. They're too dense, confusing. People can miss them or not reference them. For the HIB job aids, we gave both an algorithm format and a table format. 2/3 preferred the table to the algorithm. 2 participants had no preference. For the tetanus toxoid containing vaccine job aids, we showed them tables that were combined with other vaccines, as well as a table that just used DTaP Tdap as the vaccine for the table. The preference between those two, it was pretty evenly split, but there was a slight preference to make sure that we just use a table that discusses tetanus toxoid containing vaccines alone and not try to combine all of the vaccines into one table. The childhood schedule already does that in a way. So so some participants felt version 1 was a little easier to read and provided a lot of information, but there was a slight preference, I think, to kind of have a separate table for the tetanus toxoid containing vaccines. The meninge and pneumococcal IAC job aids were provided as part of this qualitative research. Each of those tables are only on one page. Providers liked these a lot and have always liked them a lot. They're clear, easy to read. There were some comments about highlighting or bolding certain sections, moving footnotes directly into the table. The important thing is most participants preferred tables to algorithms, and so and that's what IAC does, and that's what we're doing moving forward with our product. So overall, people liked these job aids. They thought they'd be a helpful resource, and they're happy that we're creating something to help them with reading the current catch-up schedule. The best summary of what they said in text responses from a participant was it should be clear, concise, and correct. Easier said than done sometimes, but that is the challenge. So the next steps, the job aids, we're going to refine them. You have one in front of you, and we're happy to take some comments on that. We want the committee to review it and offer us comments over the next several weeks. These are going to be CDC documents, clearly noted as an adjunct to the published child schedule table to assist with schedule interpretation. And so I'd like to thank Dr. Renee Jenkins and the Childhood Adolescent Workgroup, as well as the Immunization Action Coalition and all of the CDC staff who've put in a lot of effort to translate the complicated schedule into something, I think, a little easier to read. So thank you very much, and I'm happy to take any questions.
Thank you, Dr. Kroger. I'll just comment that in my clinic, 90% of the questions I get from particularly our medical assistants deal just with this question alone. And having a flow-through table, I think, is going to be very beneficial as compared to just the current tool. So thanks to the work group for this effort. I see Dr. Herman's hand up.
Yes, I was just going to ask if there's a goal to work with the manufacturers of electronic medical records to get these get these programmed in, because that would really be optimal.
Absolutely, and that's been an ongoing project with the registry branch of our division to make sure that the information in the CDC childhood schedule, as well as the general recommendations, because the childhood schedule has the tool for moving forward for someone with a lapsed schedule. The general recommendations has the table that's useful for back validating, or as the registry language, validation is called evaluation, and forward thinking is called forecasting. So we are working with the registry group to make sure that ACIP recommendations, the most important thing to them is that they want to program in what ACIP recommends. They've said that repeatedly. These job aids are going to be harmonized with the childhood schedule. So it doesn't matter whether you use the job aid or the schedule to talk to the registry. But yes, they do need to be harmonized.
Just to follow up, I mean, beyond the registry, I guess I was thinking of the electronic medical record system such that reminders and pop-ups, this child is due for this particular dose today based on its prior history, et cetera.
Absolutely. I mean, I might defer to others, but I think there is a process to also harmonize the way the registries function with medical records as part of meaningful use. And so, yes, that is kind of an ongoing concern and consideration.
Dr. Shuket.
Just to comment that there's both work going on with electronic medical record vendors, but sort of the ideal circumstance is the bidirectional information flow between electronic health records and registries, so that in a single application, you open your electronic health record, it queries the registry for all relevant doses and tells you what you need to do now, so that you're not just limited to the vaccinations in your electronic health record, but take advantage of the rest of the system. It's a major priority for us and the Office of the National Coordinator.
Yes, Ms. Groom.
Thanks, Andrew. And as you know, we actually just had a question regarding Hib vaccine in the catch-up schedule, so I'm really happy to see these job aids and would love to follow up with you afterwards, because I'm still seeing a contradiction in the catch-up schedule about whether or not one of the children in the case that we presented to you would need the booster dose or not, because as I read through the language and try to unpack it, I can come to two different conclusions based on the current language. So perhaps you can follow up and walk me through that.
Definitely will do that. Yeah, the issue is one of, I believe, beginning vaccination at 7 months or older and getting 3 doses in. Do you need that dose at 12 months of age or older? So we do need to follow up on that and make sure we have SME input on that point.
Any other question or comment? Okay. Dr. Bocchini, if you can introduce a section on yellow fever vaccination.
Good morning. In October of last year, the JE Vaccine Workgroup was tasked with evaluating the World Health Organization decision for continuation of a booster dose for yellow fever vaccine. So we changed our name and then modified the membership of the workgroup to bring on the expertise that we needed to evaluate the question we were asked to solve. Today, we will present a grade evaluation of the information and evidence that's available on the use of yellow fever vaccine booster doses. Dr. Staples will provide this information and provide you with the workgroup conclusions and the evaluation that we've completed and the recommendations that we would like you to consider in making the decision about use of booster doses. So following presentation, we'll have discussion, and then this will lead to a vote. So I want to just go back and give you an overview of some of the key issues. Since 1965, the international health regulations allowed countries to require a yellow fever vaccine dose within the past 10 years for entry into the country. In April of 2013, the World Health Organization Strategic Advisory Group of Experts, SAGE, concluded that a single dose of yellow fever vaccine is sufficient to confer sustained immunity and lifelong protection. Therefore, booster doses were no longer considered to be needed. However, the World Health Organization SAGE group did identify that there were specific risk groups which might benefit from a second dose or a booster dose in its recommendations. Now, yellow fever vaccine is the only vaccine covered by IHR, and IHR does stipulate that the vaccine does provide protection against infection for 10 years. Therefore, if a country decides to require yellow fever vaccination, the certificate that's provided with a dose of vaccine is valid for 10 years. Now, in May of this year, the World Health Organization World Health Assembly did adopt an amendment to the IHR that extends yellow fever vaccine protection to the life of the person vaccinated. So therefore, they will no longer recommend booster doses, and the change in the IHR will become official in June of next year. June of 2016. Apologize. So the current ACIP recommendations were for yellow fever vaccine were updated in 2009 and published in 2010. And currently, yellow fever vaccine is recommended for those persons aged 9 months and greater traveling to or living in areas at risk for the yellow fever virus transmission in both South America and Africa. And in addition, the vaccine is recommended for laboratory workers who are exposed to virulent virus strains in their routine work. Per IHR, yellow fever vaccine may be required by a country for entry at intervals of 10 years. Also in the recommendations are the following statements. Because of the risk of serious adverse events, healthcare providers should vaccinate only persons who are at risk for exposure to yellow fever virus or require proof of vaccination for country entry. And also this statement that IHRs require revaccination at intervals of 10 years to boost antibody titer. Evidence from multiple studies demonstrates the yellow fever vaccine immunity persists for many decades and might provide lifelong protection. So in essence, ACIP has followed IHR recommendations, but not specifically made recommendations about the use of the vaccine. So yellow fever vaccines are live attenuated vaccines. They were developed initially in the 1930s. The only yellow fever vaccine available in the United States is the 17D204 strain vaccine, Yellow Fever Vax, manufactured by Sanofi Pasteur, and over 540 million doses of the vaccine, yellow fever vaccines, have been administered worldwide. There have been no human studies performed to determine the efficacy or identify a correlate of protection for yellow fever vaccine. One study did establish minimal level of neutralizing antibodies needed to protect monkeys in studies against virulent yellow fever virus, and this was developed as a log neutralization index, this is now not used for evaluation of antibody response in humans given the vaccine. They're typically tested with a plaque reduction neutralization test, the PRNT test, but there's no correlate determined for this more commonly used test of protection as well. It's also not known whether a lack of detectable antibody, decreasing titers that become non-detectable over time in previously immunized persons indicates susceptibility to yellow fever after exposure. So as I mentioned, our work group was reformed to include yellow fever vaccine in October of 2013. We've met 12 times to discuss yellow fever vaccine booster doses. During these teleconferences, we reviewed the duration of immunity following yellow fever vaccine and the safety of yellow fever vaccine booster doses. We've completed the grade analysis, reviewed the epidemiology of yellow fever vaccine in yellow fever and use of vaccine in travelers, and we've developed some proposed recommendations, as I indicated, for your consideration. We've given you two previous presentations on this topic. One was to review the work group charge and its plans, and in February of this year, we reviewed the disease and the vaccine background information for you to prepare for this meeting. I want to thank the members of the committee. As I said, it was reformed to include subject matter experts, travel medicine experts who work with yellow fever, and I specifically want to give my thanks to Erin Staples for the work that she's done as the CDC lead for the committee. So with that, we'll turn this over to Dr. Staples for a presentation. Thank you.
Thank you, Dr. Bikini. And good morning. The work group used grading and recommendation, assessment, development, and evaluation, better known as GRADE, to review data related to yellow fever vaccine booster doses. The 9 steps of GRADE are shown here. During my presentation, I will go through each of these steps as it relates to the workgroup considerations for yellow fever vaccine booster doses. The first step was to develop a policy question. The primary policy question developed by the workgroup was as follows. Should booster doses of yellow fever vaccine every 10 years continue to be recommended for healthy travelers and laboratory workers? This included healthy travelers and laboratory workers as the population. The intervention is to remove the current recommendation of booster doses versus the current option was to continue the current recommendations for yellow fever vaccine booster doses. Next, the workgroup identified and ranked importance of outcomes related to this policy question. There are 4 benefits assessed by the workgroup, including vaccine efficacy, vaccine effectiveness, as measured by vaccine failures, seroprotection, and seropositivity. Although efficacy and seroprotection were considered critical, there are no data available for these. Given this, seropositivity, which was originally assessed by the workgroup to be important, was changed to critical. So vaccine effectiveness and seropositivity was considered critical by the workgroup and were included in the evidence profile. There are 5 harms assessed by the workgroup, including serious adverse events, 2 known yellow fever vaccine-associated serious adverse events, namely viscerotropic disease and neurologic disease, and then anaphylaxis and systemic adverse events. Serious adverse events, viscerotropic disease, and neurologic disease were considered critical by the workgroup and were included in the evidence profile. Next, we searched and reviewed published and unpublished data. To do this, we performed a systematic search and review of published literature. We identified 32 studies that reported primary data relevant to the critical outcomes. In addition, we reviewed unpublished data from 3 sources. Data from the Brazilian Ministry of Health on the duration of immunity and vaccine failures. VAERS reports from yellow fever vaccine administered January 2007 through December 2013. And finally, CDC's arboviral diseases laboratory data on antibody titers and vaccine recipients 10 or more years post-vaccination. Next, I'll present a series of slides that summarizes the evidence for the critical outcome. This slide shows the 5 studies that have data on vaccine effectiveness as measured by vaccine failures reported following yellow fever vaccination from 1940 through 2013. The population in the first column is either noted as non-endemic. This would include travelers, laboratory workers, or military personnel from areas without yellow fever virus transmission, or an endemic population that includes persons who live in areas at risk for yellow fever virus transmission. The next column is the type of study, where OBS means observational study. Next is the number of yellow fever cases that occurred in persons who reported being vaccinated against yellow fever. The next column is the number of cases who had laboratory testing that supported the diagnosis of yellow fever. And the last column is the time post-vaccination when yellow fever disease occurred. As you can see here, there's been few vaccine failures documented following that yellow fever vaccination over the last 70 plus years. All but 2 cases where the data are known occurred in persons who reported receiving yellow fever vaccine within the last 10 years. There was 1 vaccine failure noted 20 years and 1 at 27 years post-vaccination. To summarize the vaccine effectiveness data, there have been 18 vaccine failures noted for among over 540 million doses of the vaccine delivered. There are limited data on the majority of cases that support actually the diagnosis of yellow fever. 16 cases or 89% of the vaccine failures occurred in persons who received a dose of yellow fever vaccine within the last 10 years. 2 vaccine failures occurred 10 or more years from the last dose of yellow fever vaccine. The next 2 slides list studies that contain seropositivity data 10 or more years following yellow fever vaccination. Similar to the table on vaccine effectiveness, the first column contains the population from where the data are derived, and the type of study, specifically observational. The third column depicts the test and the cutoffs used to establish seropositivity. There are two primary assays noted, the mouse protection study, which are no longer being used, and the more modern assay, the plaque reduction neutralization test, or PRNT. For the PRNT, different cutoffs were used for virus inhibition, as well as different titers were used to define seropositivity. The next column is the time post-vaccination, and then the numerator of those who were seropositive over the total number of persons in the study, and finally the proportion that are seropositive. The 7 studies on this slide contain data starting at 10 years post-vaccination and range from 77 to 100% of the subjects being seropositive. This slide contains 6 more studies with seropositivity data up to 69 years post-yellow fever vaccination. The range for those that are seropositive among these studies is 75 to 97%. To summarize, there's been 13 observational studies with immunogenicity data for 1,137 persons vaccinated 10 or more years previously. If you add up the numerators, there was 1,002 persons, or 88%, who are seropositive 10 or more years post-vaccination. However, when you account for the study size differences and variability between the studies in a meta-analysis, the estimated seropositivity is 92%, with a 95% confidence interval of 85 to 96%. The proportion decreases to 80% by 20 years post-vaccination, but there are only 164 persons for whom there are data. The estimated seropositivity from the meta-analysis is also 80%, with a 95% confidence interval of 74 to 86%. Now to move on to the data about potential harms. For all harms, we included studies that had denominator data, or more specifically, the number of adverse events per the total number of doses distributed or administered. There were 9 studies with data on serious adverse events. The studies included data from 1990 through 2013, and all studies were observational. The 4th column notes the number of doses accounted for in that study in the thousands. So for instance, for the first study, that would actually be roughly 3 million doses of the vaccine. The final 3 columns note the number of cases by dose type, either primary or initial vaccination, a booster dose, or if the dose type was unknown. To summarize the serious adverse events, there were 9 observational studies from manufacturers and national surveillance data that accounted for 333 million doses of the vaccine administered. However, it's unknown of these total doses how many were administered as primary versus booster dose, so we cannot determine rates. There were 1,255 subjects who reported a serious adverse event following yellow fever vaccination. For the vast majority, 84% of the subjects, the dose type was unknown. 7% for whom the dose type was known and who reported a serious adverse event that occurred following a booster dose of the vaccine. This slide shows studies reporting viscerotropic disease cases and denominator data. One thing to note is that a number of these cases could have been included on the serious adverse event table I just showed you. The studies include data from 1990 through 2010 and range from studies that have 42,000 doses up to 276 million doses administered. As you can see here, there was 1 viscerotropic disease case noted following a booster dose of yellow fever vaccine. To summarize, there were 8 observational studies from manufacturers and national surveillance data that included 437 million doses of the vaccine administered. Again, it is unknown how many of those doses were given as primary versus booster doses. Overall, there were 72 subjects who were reported as having viscerotropic disease, and 57% of the subjects, the dose type was unknown. Finally, 3% of the subjects for whom the dose type was known and were reported as a viscerotropic disease case occurred following a booster dose. This slide shows the number of studies reporting neurologic disease cases and denominator data. Similar to the viscerotropic disease cases, these cases may have been presented on the serious adverse event table shown previously. The studies included data from 1990 through 2010 and 3 neurologic disease cases were reported following booster doses of the vaccine. To summarize, there were 8 observational studies from manufacturers and national surveillance data that accounted for 462 million doses of the vaccine administered. However, the number of doses that were administered as a booster dose is unknown other than for one study. There were 218 subjects who reported neurologic disease following yellow fever vaccination. Of these, 50%, for 50%, the vaccine type was unknown. 3% of subjects for whom the dose type was known and for whom neurologic disease was reported occurred following a yellow fever vaccine booster dose. Now to evaluate the quality of evidence for outcomes. This slide shows the evidence type used for grade. The highest evidence type is 1. That includes randomized controlled trials or overwhelming evidence for observational trials. Next is 2. That includes randomized controlled trials with important limitations or exceptionally strong evidence from observational studies. Type 3 is observational studies or randomized controlled trials with notable limitations. And evidence type 4 is clinical experience, observational studies with important limitations, or randomized controlled trials with several major limitations. Here are the limitations and evidence type for benefits of yellow fever vaccine booster doses. For vaccine effectiveness, there are 5 observational studies that had a risk of bias as there was incomplete case capture and no comparison group. That was also further downgraded due to the indirectness, as the majority of data were from endemic areas, and it's unknown how many persons at risk for yellow fever would not have received a booster dose of the vaccine. The final evidence type is 4 for effectiveness, vaccine effectiveness. For seropositivity, there were 13 observational studies. They had the same limitations, with the risk of bias coming from those who might have been tested for their long-term seropositivity, and indirectness, again, due to differences in the population, as well as the fact there is no vaccine efficacy or seroprotection data available. And finally, different assays and different cutoffs were used to assess seropositivity. The final evidence type for seropositivity is type 4. Here are the limitations and evidence type for the harms of yellow fever vaccine booster doses. There were 8 to 9 observational studies related to each of these. All harms were downgraded due to indirectness, as it was unknown for all but one study the number of doses that were administered as booster doses versus primary doses, and thus the rate of serious adverse events could not be calculated. The evidence type for any serious adverse event, viscerotropic disease, and neurologic disease were all type 4. The overall quality of evidence for critical outcomes used to assess yellow fever vaccine booster dose was type 4, the lowest evidence type. Before moving into the value assessment, I wanted to discuss an additional policy question considered by the work group, as the primary policy question was for healthy travelers and laboratory workers. The additional policy question was created for special populations whose initial immune response to yellow fever vaccine may be suboptimal. The question was, should booster doses of yellow fever vaccine every 10 years continue to be recommended for travelers and laboratory workers who had a precaution to vaccination that might have negatively impacted their immune response to their primary dose of the vaccine, such as pregnancy, asymptomatic HIV, or age 6 to 8 months? There are very limited data related to the special populations whose immune response to yellow fever vaccine may be suboptimal. Therefore, the work group decided not to perform grade. But the immunogenicity data was reviewed and discussed for pregnant women, HIV-infected persons, and young children, and I will now present those data. Regarding the immunogenicity of yellow fever vaccine in pregnant women, the 2 studies that have been published on cohorts of pregnant women show that the proportion of who develop antibody titers after yellow fever vaccination is variable. One study found 39% of pregnant women vaccinated during their 3rd trimester seroconverted. This is in comparison to 92% of the general population from the same area. In the second study, 433 pregnant women vaccinated primarily in their 1st trimester were found that 98% developed yellow fever virus specific neutralizing antibody titers. There have been 2 studies that have been published with immunogenicity data on HIV-infected persons that have a comparator group and were beyond the first 1 to 2 months post-vaccination. In the first study, performed retrospectively among HIV-infected travelers, 83% had yellow fever virus specific neutralizing antibodies 1 year post-vaccination, compared to 97% of uninfected controls, and this difference was significant at a p of 0.01. The second study found only 17%, or 3 of 18, HIV-infected children in an endemic area of Africa had yellow fever virus specific antibodies at 10 months post-vaccination. This is compared to 74% of age and nutritionally matched unaffected children. This table shows 9 studies on the seroconversion rates 1 to 2 months following a primary dose of yellow fever vaccine in young children from endemic areas. Studies included on this table are those that have been published since 1980 and thus would use vaccine formulations that are currently in use today. The first column shows the age group in months, then the study type, which does include some randomized control trials. All but one of the studies was designed to look at the potential immune response when yellow fever vaccine was co-administered with another vaccine. Again, the assays used were variable between the studies, and each study had at least 100 children, up to 900 children in one of the studies. The seroconversion rates ranged from 78 to 96%. To summarize, there were 9 studies that included data on children 6 to 36 months of age in endemic areas. From these studies, 98%, or 2,433 of a total 2,754 children, seroconverted 1 to 2 months post-vaccination. There are very limited long-term immunogenicity data beyond the first 1 to 2 months post-vaccination available for children to know if their antibody decay rates would be different than adults. Now I'll present the assessed values related to the options and outcomes. From 1970 to 2013, there have been 10 yellow fever cases reported among travelers from the United States and Europe. 9 of the 10 cases were in unvaccinated travelers, of which 8 died. 1 traveler reported receiving yellow fever vaccine 5 years before traveling to West Africa, where she developed yellow fever. She survived. Yellow fever vaccine has been available, despite the presentation earlier, we missed yellow fever on that slide, but ACIP's considered it, has been available since the late 1930s and is currently unknown how many cases the disease have prevented due to vaccination. Overall, though, the vaccination coverage rates reported from airport or clinic surveys in persons traveling to yellow fever endemic areas is high at 91 to 93%. The risk of yellow fever disease and death in an unvaccinated traveler for a 2-week stay in West Africa has estimated to be about 50 disease cases and 10 deaths per 100,000 population. In South America, the risk is estimated to be 5 disease cases and 1 death per 100,000 population. The risk of yellow fever disease varies based on location, duration, season, and activities. The worker group agreed that the risk of yellow fever will be lower in persons receiving at least 1 dose of yellow fever vaccine 10 or more years previously, but it's not quantifiable given the lack of available data. The work group discussed some additional considerations regarding disease risk in a U.S. population. Overall, the work group considered persons who might be at higher risk of exposure to yellow fever virus based on a number of factors, including location, with the disease risk being 10 times higher for West Africa than South America, the duration of travel, with longer travel, e.g. months to years, likely to increase the disease risk, and the type of exposure, such as a more consistent exposure to virulent virus among laboratory workers. For each of these, there are minimal to no data to support these considerations of increased disease risk. In the end, the values considered by the work group during the grade process were Yellow fever is a severe disease with substantial mortality. There's no specific treatment for the disease. There's a safe and effective vaccine available to prevent the disease. Furthermore, there's a low probability of serious adverse events with revaccination. Vaccine prevents importation and spread of yellow fever virus. And finally, the vaccine is expensive. Which moves me into the review of the health economic data. There are no data on the cost effectiveness of vaccinating travelers, either with a primary or booster dose of yellow fever vaccine. Providing yellow fever vaccines to all travelers going to endemic areas would not be cost effective, as there's a large number of travelers to endemic areas, approximately 3 million per year. The risk of the disease in persons who's already received a dose of the vaccine, so we'd be looking at booster doses, is less than 5 to 50 cases per 100,000 population. And finally, the cost of the vaccine varies $150 to $350. Traveler vaccines are usually paid for by travelers themselves. These vaccines are not covered by most private insurance. They are also not covered by vaccines for children. Given this, the work group decided not to perform a cost-effectiveness study on yellow fever vaccine booster doses. Now to discuss the considerations for formulating recommendations. There are 3 potential recommendations considered by the work group to begin with. First is a booster dose of yellow fever vaccine every 10 years is recommended for travelers or laboratory workers. Next is a single dose of yellow fever vaccine is sufficient to confer sustained lifelong protective immunity against yellow fever disease, and a booster dose is not necessary, which is the language that WHO and SAGE used in their recommendation. And finally, booster doses are no longer recommended for most travelers or laboratory workers. However, booster doses are recommended for certain persons at risk for yellow fever virus exposure. When formulating the recommendations to present to ACIP for the consideration, the work group considers there's been very few vaccine failures noted following yellow fever vaccination. Most, or 92% of vaccine recipients, are seropositive 10 or more years following or post-vaccination. Serious adverse events are uncommon following booster doses of yellow fever vaccine. A high value is placed on preventing a serious disease with no treatment and poor outcome. And finally, the current statement in ACIP recommendations regarding booster doses will soon be antiquated, as international health regulations will remove the language of yellow fever vaccine booster doses in June of 2016. As a reminder, the language that's currently used in the ACIP recommendations that have been in place since 1964 says that in international health regulations require revaccination at intervals of 10 years to boost antibody titers. Based on the grade process, review of additional data, and subject matter expertise, the work group reached the following conclusion. A single dose of yellow fever vaccine provides long-lasting protection in most travelers. The work group proposes no longer recommending a booster dose of yellow fever vaccine for most travelers. Based on limited data, the work would recommend a yellow fever vaccine booster dose in certain persons, either at increased risk for exposure to yellow fever virus or whose immune response to their previous dose might have been compromised due to an existing condition at the time of vaccination. This brings me to the final ACIP recommendations in grade category. The work group proposes the following wording for ACIP's consideration. Booster doses are no longer recommended for most travelers or laboratory workers. That would be a recommendation category A. This slide contains 2 options. However, based on limited data, a yellow fever vaccine booster dose is recommended for certain persons either at increased risk of exposure to yellow fever virus or whose immune response to their previous dose might have been compromised due to an existing condition at the time of vaccination. This would be a recommendation category A. Or the alternative is essentially the same wording, but instead of stating it's recommended, stating that booster doses may be considered for certain persons. And this would be a category B recommendation. This slide includes language for certain persons for whom the work group would recommend or consider booster doses based on an increased risk. Travelers who received their last dose of yellow fever vaccine greater than or equal to 10 years previously and plan to stay in an endemic area for a prolonged period, e.g. months or longer, and plan to travel to a highly endemic area of rural Africa. An alternative consideration that the workgroup discussed would be to remove the examples in parentheses as they're based on limited data. The next statement to consider for booster doses for increased risk would be laboratory workers who routinely handle infectious virus and who have no detectable yellow fever virus specific neutralizing antibodies, or who received their last dose of yellow fever vaccine greater than or equal to 10 years previously, and for whom yellow fever virus-specific neutralizing antibody titers are unavailable. This slide includes language for certain persons for whom booster doses would be recommended or considered based on a potential suboptimal immune response to their previous dose of the vaccine. Persons who received their last dose of yellow fever vaccine greater than 10 years previously and who had at the time of their last vaccination a condition that might have compromised their immune response to that dose, e.g. age less than 1 year, pregnancy, or HIV infection. Second statement to consider for vaccine booster doses for a suboptimal immune response are persons who had an intervening condition since their last dose of yellow fever vaccine that might have substantially impact on their memory immune response, e.g. a bone marrow transplantation. Based on the review of the data and the gaps that exist, the workgroup had the following recommendations for areas of further study. Assess neutralizing antibody levels greater than 10 years post-initial vaccination in travelers. Evaluate an amnestic immune response to revaccination in persons without detectable antibodies. Determine seroprotective levels of antibodies using the plaque reduction neutralization test by correlating it to a log neutralization index greater than or equal to 0.7. Establish a role of vaccine-induced cell-mediated immunity in long-term protection against yellow fever, and assess neutralizing antibody levels among persons with suboptimal immune response to yellow fever vaccine. As long as the chair agrees, I'd like to open this presentation up for questions and discussion, as well as a vote on no longer recommending booster doses for most travelers, and also on a vote of whether to recommend or consider yellow fever vaccine booster doses in certain persons. And just to note, there shouldn't be a BFC vote. And I'll end by just again acknowledging the workgroup members who provided invaluable discussion and input on yellow fever vaccine booster doses. And thanks to Joe for steering this through a somewhat interesting conversation along the way.
Thank you very much, Dr. Staples. I'd again like to commend the Yellow Fever Workgroup for just a very thorough and understandable presentation. Also, just an example of a Category A or strong recommendation based on Level 4 data and evidence, which is perfectly acceptable. But the nice thing here is it lays out all the evidence in a very transparent manner for everybody to see. We're open for any questions or comments regarding Dr. Harrison.
So is there anything to be learned from the vaccine failures themselves? Is there something different about them, immunologically or otherwise?
Yeah, so the vast majority of the vaccine failure data, or I should say, it comes from endemic areas to begin with. And some of them actually are from the 1940s from military personnel. So the stuff that we have from non-endemic or people that were stationed in Africa during World War II. So the data on those cases themselves are old case reports themselves. There's very few recent vaccine failures that have been documented. They have been documented in Brazil. Those are the most recent ones. The testing has been performed on those cases, but actually understanding what it was about that original person. But just to remind you, in clinical trials, when normal, healthy adults or children are given the vaccine, in general, there's a good seroconversion rate of greater than 99%, but a small proportion of persons might not respond to that initial dose. But there's nothing in common from the few vaccine failures that we note that could denote who might be at risk.
Dr. Dushan.
Thank you. Thank you for that presentation. It's very well done. My question is about the lumping together of all persons vaccinated greater 10 or greater 10 or greater years after vaccination, because I'm thinking that it's likely that, you know, as immunity probably wanes with duration from vaccination, so those vaccinated at 11 years probably are going to be more likely to retain some evidence, indirect evidence of protection versus those vaccinated 30 or 40 or 50 years ago. And I'm wondering, first of all, if any of the data that you presented in slides 11 or 12 could be further analyzed to look at whether or not the seropositivity rates are lower the farther out you get from vaccination, because it looks like some of those studies that assess years post-vaccination, greater number of years post-vaccination, have maybe slightly lower rates of seropositivity. And I worry a little bit about someone who is vaccinated, you know, in their teens or early 20s and then wants to return to an endemic area at age 50, 60, or 70, whether that person should be subject to the same recommendations as someone who was vaccinated 11 years ago.
Yeah, the work group had discussions on that, and I tried to, during that presentation, give you kind of the meta-analysis for 10 years or more versus 20 years or more, and it does suggest there is at least a decrease, though it's not significantly different between those two. The problem is the further you go out, we just don't have good data. We have very minimal numbers of subjects that have been followed that long. There are plans actually currently to do a study working with the military to look at people that might have been vaccinated at longer terms, but even then the numbers will probably limit us from making firm conclusions. So we do have data plan to, or at least studies plan to look at that potential decay over time. But I should note that the work group did discuss this option and said, well, what is it? Is it 20 years? Is it 30 years? What is it? And right now we just don't feel that there's enough data to firmly establish a cutoff for a 20-year, and also that might even further complicate, you know, what we're proposing is somewhat complicated recommendations in terms of subcategories to consider a booster dose. So there was some discussion, and I don't know if Dr. Pacchini wanted to add anything to that, but there was some consideration, but we decided not to go forward at that time, mostly due to the lack of data.
Dr. Plotkin.
Age makes sense because they're referring to endemic populations, and revaccination of populations subject to endemic yellow fever is a major public health issue. So I can understand why they wouldn't recommend boosters. But here we're talking about, essentially in the US, travelers who will want the maximum protection possible. Now, another point relates to the correlate of protection. Now, I don't have the papers with me, but I do not agree that there is no correlate of protection. There are studies, for example, that have been done not only in monkeys, but in other animals, suggesting the titer, neutralizing a titer of 1 to 40 is equivalent to protection, which of course means that titers lower than that may not protect. And in that regard, if you look at GMTs of a population, that's fine, but you have to also look at those who fall below the GMT. And there are studies, I'm quite aware of studies that show that with falling titers with duration from the initial vaccination. I remember one study by Niedrig, I think was the first author of that study. So that has to be taken into account as well. And in relation to Dr. Duchin's question, yes, there is waning of antibody with time, and there are data that I've seen, compendia of data that show that no matter what study you look at, antibody falls with some so that some percentage is below the likely protective titer long after vaccination. And you mentioned the issue with children, and that's an important issue because children do not respond as well to yellow fever vaccine as older individuals. So if I were writing the recommendation, I would recommend a booster dose for children at 10 years, one booster dose. I'm not saying that everybody needs to be vaccinated every 10 years, but there is a need, I think, in certain populations like children for a booster dose. I'm also aware that in Brazil, where they use mass vaccination against yellow fever, there have been 2% of individuals who have had yellow fever have been vaccinated. So there are primary failures as well as secondary failures, and they often occur in children. Just let me say also that in relation to laboratory workers, okay, well, the vaccine is expensive, but if I were a laboratory worker, I would certainly want to at least have a high neutralizing titer, or if not, I would definitely want to be boosted. So I think this, oh yes, in relation to the anamnestic response, yes, there are data on anamnestic responses to yellow fever, and indeed those who have low titers do respond. So again, in summary, although it's hard for me to speak to specifics without having the papers in front of me, I think this recommendation goes too far for travelers. I think they should have, if they're going to a yellow fever endemic area, they should have at least one booster after 10 years.
Dr. Ornstein?
I have just one comment, and perhaps I don't understand, and I'm looking at slide number 46 about booster doses, and the implication is that if you have somebody who was vaccinated, let's say at age less than 1 year during pregnancy or had HIV infection, one had to wait until at least 10 years to give another dose. And then if I look at slide number 27, you show that only 39% of women in the first trimester seroconverted. Only 17% of HIV-infected children seroconverted at 10 months. It seems to me that the 10-year is not appropriate, that if someone is taking another trip, they ought to get vaccinated no matter what the interval is in there. And I don't know if there was if that is still permissible, but the way I read that is you have to wait 10 years before you would give another dose.
Yeah, and that phrasing was discussed highly in the work group regarding the same principles, that in fact some of these populations may have more rapid waning immunity, that you might want to boost them sooner. However, the data to know, for instance, when they would be boosted, it would be an easy solution to boost them before their next travel. But what if you had an HIV infected person who traveled 3 or 4 times a year on a regular basis to an endemic area? Are you going to be boosting them every time that they go? And we didn't feel that we had enough evidence to actually say when did they needed to be boosted. So we did, at least at this time, favor putting in 10 years, but you are correct that it would be probably wise to go ahead and boost them before they travel again. But that was, again, something we discussed in the work group. And Dr. Bocchini has some additional information.
Yeah, I'll just add that, Walt, that was discussed in detail. And we had the problem of that it's never been recommended to give this vaccine, because of the low seroconversion rate, to give it earlier. And so we tried to stick with the primary recommendation for booster doses in 10 years, no shorter than 10 years. But raised the issue that is something that needs to be studied, and that's one of the questions that's unanswered because there is no data.
Dr. Schmieder.
Thanks, Ken Schmader, American Geriatric Society. What a great presentation. Another factor to consider in the adverse event side of things is age, because it's well known that older adults are at increased risk for serious adverse events from yellow fever vaccines. Did the work group include that in their considerations?
Yeah, so the risk of serious adverse events with older age has been shown, at least in one more recently published study, to be relative to the primary dose, because the primary dose is where you get the actual low level of viral replication. And they showed when you looked at older adults, and I won't define that group just to make anybody feel uncomfortable in this room, but when you looked at older adults, their levels of viremia were higher in comparison to younger adults, as well as it took them longer to develop more antibodies. And so right now in the ACIP recommendations, age greater than 60 years is actually a precaution to the primary dose of vaccination. When it comes to the booster dose, because generally, ideally, you should be getting some sort of amnestic response. And in general, when they've looked at people that are getting booster doses, most of them do not have actively replicating virus. The risk of a serious adverse event due to yellow fever vaccine, was thought to be negligible. However, in general, a lot of studies have shown that older persons are at risk for serious adverse events following any vaccination as they get older. So that was a brief discussion that we had, but when we were looking predominantly at booster doses, we did not take that into consideration.
Great, awesome. The definition of elderly is 10 years older than the oldest person in the room.
A follow-up to Dr. Schmader and maybe to Dr. Grog as well in travel medicine. I'm curious, with the grain of the baby boom generation, are we seeing more and more first-time vaccinees in the 60s or older receiving yellow fever because of retirement and international travel?
Yeah, yes, definitely. There are a lot of persons who are aging well, if you will, or successfully in their 60s, 70s, and 80s and traveling around the world, and this is a very important issue.
Thank you. Dr. Farhofer.
Yeah, I would agree with that situation. The biggest problem is the cost, and will it be accepted if the ACIP makes a recommendation in other countries? That's a concern. But if you don't make the recommendation, they certainly won't.
Sandra Fryho for American College of Physicians. For patients that have an initial yellow fever vaccination that are in a group that you would think they would probably respond well, and they're going back to visit another country, I noticed that in the data it says, in the presentation it says that this is not going to become a formal recommendation from the international group until 2016. Is there any list of countries that require the vaccination now, or when they'll be going to that new recommendation to sort of help us decide who would need a booster if they're going to enter that country? Or is there any way to get that information?
Yeah, so that information is readily available on the CDC Travelers Health website. We actually have people devoted in our Traveler Health group that contacts every country and checks into regulations, if not every other year, then, as regulations change. So that's also published in the Yellow Book, which is the Travel Health Recommendation book. But I would recommend going online, because if there are updates between when the book is published every 2 years, then you can find the information about which country currently requires proof of yellow fever vaccination. We will be incorporating, as countries choose or choose not to accept to do booster doses, that additional language. For instance, we've received some feedback that some countries may still continue to require booster doses, and we will have to provide that information, and that information will be available real time on the CDC Travelers Health website.
Okay, so let me clarify. So whenever I have a traveler, we always check the CDC website, so I know exactly what you're talking about the countries that do require it. But have y'all started updating and saying they just require the one dose, or they require every 10-year dose? Have you started doing that more specific updating based on this new policy, international policy?
So the World Health Assembly met just last month to make the official change to the international health regulations, or at least propose that the change be made, and it won't actually go in effect until 2016. So while WHO SAGE removed booster dose requirements, international health regulations are still in place, so countries can still allow a booster dose every 10 years, but we will be incorporating that information as we know which countries are going to still require it, and as they don't require it anymore. It's a process that's going to have to be live and that we're going to continue to work on.
Yes, Dr. Moore.
Thank you, Kelly Moore from AIM. On the suggested booster dose for travelers who would be traveling for longer periods in more highly endemic areas, I think that I would love to see more specificity thinking operationally. I agree with the idea of leaving out particular locations, but if that were to be approved, I think more specific language will be essential for travel clinics to really understand what do you mean by highly endemic. Does that mean don't worry about South America, but do worry about West Africa? Some sort of sense of rates, because rates may change as you have newly endemic areas with climate change going on, demographics and rates will change. And so something that gives them a more objective sense of when do I really need to think this is important would be very valuable.
And the current ACIP recommendations actually has a section that does note when the rates would be highest in Africa and South America and the rates in those two different countries. But, as we get more information or to provide more guidance, we can. But a lot of that data already exists in the ACIP recommendations.
Any other questions or comments? Yeah.
Sorry, Jan England representing Pediatric Infectious Disease Society. I would just like to say that I have concern about putting the age line at less than 1 year there. I think we have incredible data that children less than 2 or 3 years don't respond so well. So I'm just perhaps I'm misreading it, but less than 1 year, I don't think if a child gets it at 1.5 years and then they're 30 or 40 or 50 years of age, I don't know if there's no vaccines we have that last that long to date.
Dr. Curran.
Yes, just trying to follow up on some of Stanley's earlier comments. I was wondering if we have any data on duration of protection after a single booster dose. Do we have that kind of information?
There have been very limited data looking at persons that received vaccine booster doses and their duration following a booster dose itself. And most of that is more short term, just to look at the sort of response they received. And I would say it's probably less than 10 people in the published literature. So we don't have much to draw from.
Dr. Bennett.
Yeah, I apologize, but I'm still worrying about these people who didn't respond when they got their first dose, and wanted to hear a little bit more about that and why we shouldn't consider, if we know they were at risk for not responding to their first dose, why we wouldn't consider a booster for them, and at potentially less than 10 years.
Again, I think that the work group did discuss that, but felt that we really had no data and no studies to go forward. And in fact, some of the data is very limited in terms of number of people studied. And so, again, we felt that was an area that needed further study before decisions could be made about an earlier dose or a second dose. I mean, there's been some discussion about having a two-dose series for younger children. But there's really no data on which to make that recommendation, so that's why we did not go there. But certainly recognize that needs to be looked at, and maybe rather than call it a booster dose, have it a two-dose series.
And that is a study that Brazil Ministry of Health is proposing to do and currently working on, about looking at perhaps just throw out a similarity to measles, mumps, and rubella, where they get one when they're young and then another one as they're getting into school age, and to look at that potential kinetics. But that study has not been performed, so there are no data.
Dr. Harrison.
I'm struggling because I'm getting the sense, and correct me if I'm wrong, that if we were reviewing these data routinely to review our recommendations, we probably wouldn't be making this change except for the change recommended by WHO. So I'm struggling with that issue.
Yeah, the first yellow fever ACIP recommendation published in 1969 actually used international health regulations requirements of 10 years to note that the booster doses should be given. ACIP has never recommended booster doses of yellow fever vaccine in its whole course that we've been doing that. And then probably part of that's my fault when I wrote the last set of recommendations that we didn't revisit that. But starting in April 2016, international health regulations will be no longer requiring booster doses every 10 years. So we will have to deal with some wording or recommendation about whether to do. And a lot of the work group did not feel that the data was strong enough to firmly state that booster doses needed to be given every 10 years for everybody.
Dr. Kemp?
Yeah, the issue of whether patients are in endemic areas appears to be really crucial. And I'm wondering if there's any way to look at in the studies that had longer duration, looking at immunity, where were those studies done and how relevant are they to U.S. populations? I guess that's mine.
Yeah, so from the set of the 13 observational studies, when we did the meta-analysis, at least at the 10-year cut, we did also break it out to look at differences between endemic and non-endemic populations. So, and then I don't have the statistics, so actually I probably have the statistics right here, but essentially they were not different. They were identical between endemic and non-endemic in terms of the kind of the proportion that would be seropositive at 10 years, and that was done through a meta-analysis breaking out the data. So there is not at least a perceivable difference from the data that we have available.
Dr. Reingold.
Well, let me just say, as an elderly ACIP member who's now had his 5th yellow fever shot, I support the recommendations of the working group.
Dr. Reingold, were you involved with the SAGE discussions?
I was there for the SAGE discussions, but not a member of SAGE at that time.
I should note I was on the SAGE committee that made these recommendations, so I'm quite aware of that discussion. And there was heated discussions of endemic populations versus non-endemic populations and to do or not. And there's obviously at the WHO level a lot of other considerations that we don't take into account at a U.S. traveler level about the cost of the vaccine, the availability, the coverage rates that occur in different locations, even just having enough vaccine available. So there are a lot of discussions and considerations, but and I think one of the things to point out is that SAGE had a slightly different question, and I'll move on to, just a backup slide, in terms of what SAGE's policy question was. They used basically the same data, though we had a few more pieces of data. Their question was there evidence that a booster dose is required in immunocompetent individuals to ensure long-term protection? And based on the same data, they reached the conclusion that no, there wasn't enough data or evidence that required a booster dose. So it's whether you look at the cup as half full or half empty in some degree of whether or not you take these data to mean that there are good data to support it or not good data to support it one way or the other.
Dr. Moore?
Thank you. I guess what really struck me as you presented was the very definitive slide number 10, where it basically said that 18 vaccine failures occurred over 540 million doses, and only 2 of those occurred more than 10 years after their last dose, and both occurred 20 or more years after the last dose. So that seems on its face quite striking. But then it seems like the additional conversation suggests that maybe that's an absence of all the information rather than evidence of very strong protection. Can you help me understand which that is in your view?
And that was one of the considerations that SAGE took highly as one of the reasons to move forward with their recommendations as well, was the lack of vaccine failures. But it needs to be caveated by that a lot of the yellow fever disease is occurring in areas where there may or not be good surveillance to detect yellow fever vaccine cases that occur. And so that is one issue. I think the other issue is also knowing vaccination status for some people and understanding, who and when. And then the other problem is since 1965, WHO has recommended booster doses under international health regulations. So it's uncertain how many people haven't received booster doses. So how do you put into context that, 540 million doses, how many of those are primary versus how many people have gotten routine booster doses? One thing to note is in endemic areas, it probably hasn't been a lot of people receiving booster doses in Africa, as there's been large preventive campaigns. In South America, for instance, in Brazil, they do deliver booster doses every 10 years to their population, delivering 13 million doses, of the 30 million doses that they have over a certain time period as booster doses. So it just depends on the location, the information, and the certainty behind it, and there just unfortunately is a lot of uncertainty.
Dr. Jenkins.
With the thought of a vote looming over us, the question for me is timing. There have been a number of responses that we don't have the data yet. So are people working on getting this data? I mean, is there some, anticipation that in another year we're going to have some better data? I mean, I don't have a sense of where we are in that time span.
There is unlikely to be sufficient data provided in the next few years. There are small studies that are planned that CDC is doing to try to get at these questions, but nothing is going to be earth-shattering or change. And this is, again, a vaccine that's been available since the 1930s, and the data hasn't existed up to this point. And I don't think, there's not enough onus or impetus to actually study this. I think Brazil maybe is the one that's doing the most studying, and we've had conversations with the Brazil Ministry of Health about what they're planning to do. But I think there'll be one-off studies coming out here and there, and whether or not that provides enough certainty to make firmer recommendations. In general, the work group felt that that was not going to be the case.
I think we have a situation here where the work group correctly identified the low-quality evidence to work with, and also to be commended for setting up a number of potential areas to be investigated as time goes on, should someone be willing to fund such studies. But I think we're stuck with what we have right now in terms of making a recommendation. I don't see any additional comments or questions, though I do have a question. Do we have two separate recommendations to vote on, or is this going to be a package deal?
I think we were thinking a package deal in terms of the saying, because if you make this first statement, for instance, that, if you agree that booster doses are no longer recommended for most travelers and laboratory workers, that would lead to a void that travel health practitioners would say, well, who are those that you do recommend it for? So we were considering a package deal in terms of stating these various next series of slides.
With that in mind, do we have any motions to accept this recommendation? Dr. Reingold, any second?
I'm sorry, I'm unclear. So there were some options within some of the recommendations. So like removing the duration language and.
This would be an option for consideration about whether or not you want to go and say that vaccine booster doses are recommended for certain persons or may be considered. So again, and then, basically agreeing with the statements of maybe removing parentheses or not. And if it would be helpful, we can go through each of the slides again, but this information should be in front of you, I think, in the slide set.
Dr. Coyne-Beasley?
Again, just for clarification, so 2 and 3 in particular, if we were interested in those, we would be actually not voting for the first. Is that what you're saying? Or is that like a contingency? Because the first, can you go back to the first slide? It says most travelers. So I guess what I'm trying to figure out is slide 2 to tell you which travelers would need it? Or, like how is it, or are they separate?
Yep, exactly. So this would be potentially the first statement that's written in the recommendations, that booster doses are no longer recommended. And then you would follow up with a statement, whether it be one of these. However, based on limited data, booster doses is recommended for certain persons. And then it would be followed by the next slides of those certain persons specifically that we're recommending the booster doses for.
On this slide, is there a feeling toward the is recommended versus may be considered? Dr. Bikini.
Well, I think that the feeling of the work group was more towards is recommended than may be considered because it was a Category A recommendation and it provided additional guidance for travel medicine clinics.
And Dr. Bennett.
One question is, it seems as though this first statement and the statement on the next slide, which is number 3, may be a little bit contradictory. It's the broadness of the first statement compared to the specificity of the second. So we say we recommend for persons whose immune response to their previous dose might have been compromised due to an existing condition at the time of vaccination. And then on the next, we say, but greater than 10 years, which seems a little contradictory.
You mean for, I think if I'm following you mean for this first statement on this slide?
Yeah.
Okay.
The first statement on the previous slide is broader. I'm worried it'll be confusing.
Dr. Herman?
I'm not sure, maybe this is what Dr. Bennett is getting at, but that first statement is very broad, so maybe it would be preferable to say, these are the people for whom revaccination is recommended, and just go through that rather than like broadly say most people aren't going to be recommended for it. I'm not sure if that's possible.
Dr. Harrison?
I don't mean to throw a wrench into this, but I'm wondering if we couldn't, I wonder if this could be a feedback providing session and that a more definitive recommendation come back the next meeting.
Dr. Bikini?
Certainly that's up to ACIP. If you have additional feedback that you'd like to give us and postpone a vote, that would certainly be something we would do. But if you want to modify these, what we thought was we were giving you options that would then lead you into the different categories. And if there is general agreement that most travelers do not need a booster dose, and then I think, as Kathleen said, link all these together so that these are individuals who you would consider giving a booster, or who you would recommend a booster dose for. That might solve that problem for you. And then, if those are the key issues, then potentially we could vote today.
You know, one option would be to condense this down and either bring it back later today or tomorrow morning.
Do that as well. Okay.
Just before we do that, and obviously Chair prerogative, but this was an example that we put forth for a more condensed version of what we were just saying. So that a single dose might provide long-lasting immunity. Booster doses are not routinely recommended for all travelers or laboratory workers. However, a yellow fever vaccine booster dose is recommended for certain persons at risk for exposure to yellow fever virus, particularly those with long stays or travel to highly endemic areas, or persons who are pregnant, age less than 1 year, or had HIV infection at the time of their vaccination. So that kind of distills it all into one.
Dr. Quinn-Beasley.
Okay, we can send.
Dr. Kemp?
Yeah, I just want to say that one of my problems is taken care of there, because the way it was worded before sounded as if it was counter-recommended, when in fact what you're saying is it's reasonably safe, but it's not routinely recommended. So I like that. I do want to come back to this age for children thing, though, and maybe have a little bit more discussion about that less than 1 year from people who know more than me.
Dr. Curran?
That was going to be my comment, too.
I think in terms of the data itself, I presented the table. But in general, unfortunately, there isn't the transparency to say it's 6 to 8 monthers or 9 or 3 years or anything else like that. The data usually encompasses a period up to 3 years of age. We could change that, but again, we're getting on very sparse data for which we're making those changes or recommendations. And right now, age 6 to 8 months is a precaution to vaccination in itself because of the fact of increased adverse events and potentially not seroconverting or having a good immune response.
But so do we have data, let's say children under 5, for example, do we have data to know that both their initial response and their duration of protection is comparable to older children or adults?
We have nothing on the duration of protection. There are no data.
Dr. Kemp?
So I think what we're saying is we have a dearth of data. And in that situation, I don't think we should fall back to the lowest common, recommend. I think we have to go then on expert opinion if we're going to make a recommendation. And I think expert opinion would probably dictate that 1 year is not the right cutoff.
Dr. Pickering?
Yeah, if you look at follow-up with what Jan said on slide 29, seroconversion rates following primary dose of yellow fever vaccine in children 6 to 36 months of age. I assume these yellow fever was given with measles vaccine, which is some sort of a precedent. The seroconversion rates for yellow fever seem higher than what would be expected for measles vaccine at 6 to 9 months. And indeed, the measles vaccine, when given less than a year, is not counted toward the 2-dose measles vaccine schedule because of the potential lack of response. So is there any correlation that you can make there and possibly tell us whether or not measles vaccine titers for that group also are available to do some comparisons, and whether the measles vaccine, which is a live viral vaccine, was one of the considerations in using 9 months or 1 year or 6 months or whatever?
I can look at those individual studies. I don't have the data on top of my head to know what the measles response rates were for the groups in the studies.
So, Ms. Pellegrini.
One of the other issues that was raised was the length of duration, not only for children receiving the vaccines, but for people who receive it later in life, say aged in their 20s, but then are traveling, let's say, in their 70s. Recognizing, again, it's a serious lack of data, do we want to include anything about passage of extreme amounts of time since initial vaccination?
I'm going to just toss out one of the, I think, realities in clinical practice. Patients don't come to me asking for this because of their perceived risk. They ask me for this vaccine because they're going to be traveling to a country which requires it. So I think once that requirement goes away, which it is going to go away, we're going to see a great drop-off in anyone coming back for revaccination. And so I think with this recommendation, we're dealing with, as we've mentioned, a severe dearth of actual evidence, and it is basically in the realm of expert opinion for all this, for which there's kind of a wide variety of viewpoints. With that in mind, I'm wondering if we have things here that we're comfortable with, or do we require major revisions? Right now, I think the recommendation is to recommend a single dose for people traveling, for laboratory workers at high risk, and otherwise revaccination for a select set, including people going to be residing in areas of high endemicity, laboratory workers, and individuals who may have not had a good take to the first vaccine. Does that summarize it fairly well? The question is, how much more with absolutely no evidence, how much more working do we need to do to get this at a level to which we're comfortable? Dr. Karen.
So acknowledging the complete lack of evidence, I would like to suggest age less than 5 years rather than age less than 1 year. And if people have discussion or objections to that, maybe we could talk about that.
Dr. Niewski?
Natosky with AHIP. Just a quick question regarding the minimal interval from the first vaccine. Is there any evidence or information that could help regarding that issue?
No, I mean, the only data that are available are just to look at kind of the immune response if you had given yellow fever vaccine sooner. So the scenario that was presented in this very small study that was done to look at that was if a person loses their yellow fever card and you had to give them another dose to get them that card, are you doing any harm? What are you seeing in the response? What's going on? And that study, I think off the top of my head, had less than 20 subjects in total. But from the people that received the vaccine at an interval less than 10 years, all of them already had antibodies. When you boosted them, or when you gave them the dose, they all boosted. Their antibody titers did not go as high as a primary vaccine recipient. So it was only a couple log change in it versus several log change for those that were primary vaccine recipients. And they seemed to go back, their kinetics were such, that they went back to the state of where they were prior to receiving the vaccine in a short time period, versus with primary vaccine immune response, you got a very sharp peak and then you had much more of a decay rate versus those that were already here, got maybe a blip and then went back to their previous rates. But again, this is very limited data that we have that information on.
Dr. Newsel?
Yes, I just wanted to expand a little bit on the points that both Jan and Larry made, and then I think Ruth picked up on it a bit too. This was discussed at SAGE, and there is at least one good study that looks at MMR and yellow fever vaccine, and as you know, MMR does affect the response to yellow fever vaccine if given concomitantly and not 30 days apart. So that I don't know how much the working group explored this, but that may be worth discussing in terms of what age you pick and whether this was influenced in any way by the concomitant administration with a measles-containing vaccine.
Yeah, no, the work group is aware of the concomitant administration, and we weren't specifically dealing with interference from live viral vaccine administered at the same visit. In that actual study itself, though, the seroconversion rates were, I think, with the separation of yellow fever versus mumps and measles, they were quite low, lower than what would be anticipated, but I have that study and can pull those data relatively. There actually is a study planned in Argentina to reproduce those data to understand whether or not there is truly interference occurring when you add mumps and measles and rubella in combination with yellow fever, as previous studies have shown that yellow fever and measles, when given together, do not cause a problem in terms of the immune response.
Dr. Kemp?
Yeah, I'm not anxious to gum up the works or anything, but I do feel like this age cutoff for children is, we're a little bit, not sure what to do there. And I just wonder if we really should run this by a few groups, like, I don't know if PEDS ID has had chance to look at that, the Red Book Committee, where that cutoff should be. I don't think we should make a hasty decision without input that's going to last, I guess.
I'm going to turn it back to Dr. Bocchini and for your thoughts on doing that. I think regardless, if we have an age cutoff, it's going to be fairly arbitrary wherever we make that. Right now, age less than 1 year is fairly arbitrary, and if that were expanded up to age 5, that'd be relatively arbitrary as well. But I think having input from some of since we're making a recommendation based on expert opinion, having a full level of expert opinion may be beneficial.
We did have representation from COID on the work group, and so that we did have opportunity we did have representation from COID on the work group, but I think it would be very reasonable if everything else is felt to be appropriate. We could easily look at and get additional feedback from representative organizations like PIDS and about an age cutoff and provide them with the data that we have and used in the evaluation before we make that final decision. But we can leave that open in terms of the upper age limit?
So I guess the decision is whether or not we would table this until next meeting, understanding that 3 of the members are rotating off. On the plus side, 2 of the new members are actually seating in this room and have heard the great discussion, and so that's beneficial. So I'm just looking around the table for consensus on whether we would like some additional thought in terms of an age cutoff and language, or proceed on in the next day. Dr. Bikini.
John, the only possible recommendation would be to, if everything else is acceptable, to accept these recommendations except for the age cutoff for children, and have that come back to the committee after after getting input from the appropriate organizations. I don't know whether that would be a reasonable way to do it, rather than bring the entire recommendation back by delaying the decision today.
Dr. Bennett?
My only concern about that is that I think there's also 2 alternative wordings that are quite different, actually. And I think that the committee probably wants to have an opportunity to weigh in on the wording. So we might want the committee to come back with what they think the best possible wording is and go with that.
Dr. Harrison.
This is a more generic comment on procedure, but I think for highly complex issues, it's tough to bring them for the first time to the working group and expect a vote. And so I think if there are highly complex issues in the future, that they be sort of vetted and get this sort of a feedback and then to finalize the recommendations for a vote.
Dr. Jenkins.
I just also wanted to clarify, what was the issue with the concern about seniors who travel? Was that, there's not enough evidence to be concerned about that at this point? I wasn't clear given the discussion we had about that.
With older individuals, it's actually the risk of adverse events that occur with the primary dose of vaccine, and since the considerations about booster doses, that should not apply.
So I'm just going to ask, is there consensus then to ask for thoughtful revision, taking into account the comments here, and to be brought back for a vote in October? And Dr. Bikini.
Yeah, then we certainly would appreciate then very specific comments related to the options that you were presented for Category A versus Category B, and then some of the other options that were provided for your consideration.
And that withstanding, I don't think there's going to be a need for representation of the grade. That was done very, very well. And again, 2 of our new members are in the audience here. So, and we can make efforts to do informing directly of the third person. So if that's the case, again, thanks to Dr. Staples for putting up with this deliberation, but I think this is what we are actually supposed to be doing in making complex decisions.